We are now live on YouTube.
Thank you.
And we will start in 3 minutes. Thanks, everybody. Roy, I assume you can hear me okay?
Yes, wonderful, sir. And you can see the agenda full screen, right?
Yeah.
Okay.
1 minute. And thank you, my friend from California. I'm glad you can hear well. Well, good morning and good afternoon, everyone. It's Tom Judd from IFMB CED, and it's 8 a.m. in Atlanta and 2 p.m. there in Geneva, and we welcome you all. Today, we just want to remember the vulnerable, the people that are most affected by coronavirus, both the healthcare workers and particularly the patients and their families. This is the fourth in a series of town halls with WHO and CED, the Clinical Engineering Division, and focused on pulse ox, as you know. And Tuesday, we have one on ventilators. Will be the last in the series currently on May 19th, next Tuesday. Please sign up. You know, today is a lot about how we partner with clinicians to deliver the best care possible to patients. And we have another webinar series. There was one on Wednesday this week on quality and safety and how clinical engineers uniquely contribute to that in healthcare alongside many others. And this coming June 10th, there will be one on how we partner with clinicians. So listen out for more information about that. And with that, I introduce Chair Toby Clark. Take it away, Toby.
Hello, everybody. It's a pleasure to be here. I want to thank Tom for introducing the town hall and all the work that you and your colleagues have done to put together this webinar series focused on priority medical technology applied to the pandemic. The strategic initiative put forth by Adriana Velasquez at WHO and put into action by IFMB CED is providing a high value at this very critical time. So today's topic of the WHO-CED webinar is pulse oximetry. My co-chair is Kito Fukuta from Japan. We have presenters Adriana Velasquez Berman from WHO, maybe others. We also have really honored to have Dr. Pauline Banguti from Rwanda, who will be talking on the clinical side, and Sharifu Rajabu from Tanzania will be next. And Ali, if I say this wrong, I'm sorry, Nglutalula from Tanzania also. And they will talk about the clinical engineering side of pulse oximetry. We're also lucky to have on the panel Tom Judd, Yadin David, Elliot Sloan from US, Kostika Utanza from Rwanda, Dan Schuster from Beta NGO here in the US that serves Tanzania, and also Dr. Najib Azhar from California. So without further ado, I'd like to turn this over to Adriana Velasquez-Berman from WHO.
I will thank you very much, the IFMB and all colleagues for joining this session today. I would like to share my screen now. So just bear with me 1 second. Thank you. Can you see it? Tom, is this visible for everybody?
It is, thank you.
Thank you very much. Okay, so pulse oximeters. I just wanted to make a very important statement. Pulse oximeters are a critical medical device. They're a priority medical device. They're an essential medical device. And in the case of COVID, oxygen cannot be delivered if you don't have a pulse oximeter around to be monitor your patient. It doesn't matter that you use invasive, non-invasive ventilation, pulse oximeters need to be there near to the patient. So this is a very important statement for everything concerning treatment and clinical management of a COVID patient. So pulse oximeters are in the WHO priority medical devices list for COVID. This was published about a month ago on the 5th of April. And as you can see, the very first lines are specifically on monitoring, and then you have all the options for pulse oximeter, either portable, finger tip, or tabletop. And those are needed even from first level of care, from healthcare centers, district hospitals, general hospitals, and of course, intensive care units. People will think, why in first level? Well, because that is a very good diagnostics if a patient is having hypoxia. So it could be easily and fastly referred to a hospital. The priority medical devices has been published and it is available for everybody. We keep updating these versions, but it is important that we say, and we state here, that we recommend to involve biomedical engineers in the selection, verification of the equipment and ensure training of the health workforce. So this is very important. And we also want to request here that extended warranty is given, that all accessories and consumables are needed for all these products. So in the list for COVID-19, here are other devices that we have that have to accompany the pulse oximeter. We have been talking about some of them in the previous versions and the previous sessions, and we will be talking about ventilators in the next week. The documents that we have for the technical specifications for oxygen pulse oximeters are coming from WHO publications. This one specifically was from 2019 and was done with UNICEF. But all the specifications that are appropriate to COVID, you can find them in the WHO website on COVID. This one is the one that was used as a basic to all the presentation that I will give today, and to draft the specifications that are published in the website specifically for COVID. You can all download it. It is in this website. Next. As I was referring to in the last sessions, we have oxygen systems that we require the oxygen source, the oxygen distribution, the regulation and conditioning. We have been talking about blenders, CPAPs. We have been talking about oxygen sources. We need to have the delivery, but this part is absolutely indispensable, the pulse oximeter and the multi-parameter monitor. And where do they go? Well, they go all the way from primary level, secondary level, tertiary level. Anywhere where oxygen is distributed, we really would like to have a pulse oximeter. So there are various types here in this book, and we want to acknowledge all the work that was done along with UNICEF and many other experts to publish this book, is that you have the fingertip. the portable handheld, and then the tabletop. And for each of them, basically they measure pulse rate and saturation of oxygen saturation. We have discussed, we say here actually, even in the book, which are the levels of healthcare that they should be used on. So we have specifically the fingertip can be used at home, can be used in a health center, and then the more you go to the tabletops, then you go into specialized hospitals. But they need to be all around in the ICUs, NICUs, general, medical, and outpatient areas, etc. All the whole list is here. The parameters, normally it's only pulse rate and SpO2, but you have other additional parameters for some of them. They all request probes, they all request batteries and charging cables, which have to be there. What is very important is if they can have a battery that can last more hours, if they have built-in alarms or other parameters which might be very useful. We also have some that drawbacks. For example, the fingertips are not recommended for use in neonates or very small children, can be sensitive to wear and tear, can be sensitive to temperature, can get lost. For the portable handheld, it is difficult to maintain, especially in remote areas. And for the tabletop, of course, they are less portable, but in reality, the reusable probes can be sensitive to wear and tear too, and everything will have to have their own catalog. Right now, they are both in UNICEF catalog, but also in the WHO catalog, and I will show you a screen on that. They have all the sensor, the book has the different sensor probe cable types. And of course, we suggest some of them as best options. We do have the technical specifications. For example, the SpO2 detection range should include 70 to 100%. Their resolution should be 1% or less, and the accuracy within plus minus 2% under ideal conditions. We know there are others that are much 5% or so, but that is too much to make a really good assessment of the patient. We have the standards which they should comply with. And of course, besides the quality management ones like the 13485, then we have special, the ISO 8601-2-61, particular requirements for pulse oximeter equipment besides others or medical equipment and medical electrical equipment. But this is absolutely indispensable for this. The catalog, the WHO catalog for the supply for COVID actually does include all of them. The pulse oximeter, the 3 types, along with infrared thermometer and patient monitors, and some of the patient monitors might also include SpO2. All of these, this catalog is, you can find it here on the COVID critical items in this website, and they're all available, the specifications, the catalog, and the list, and also the sources. There is another page that is very important, the website for COVID in the medical devices site. And this is a website that includes here the section on medical equipment and consumables where you can find all this information. And it is my almost last slide. It is the inventory tool for COVID-19. We've been promoting this all the times in every seminar, but we just have about 30 that have been submitted. We really need to get your data. We really need to know if there is availability of oxygen, ventilators, or pulse oximeters. So they come in a format like this. Everything is here. Please submit. There is no other way we know what are the requests and the requirements at country level. So I always use this slide to make sure that whatever is innovative and so they has to have an assessment. We have to get the regulatory approvals, and then we need to ensure that there is post-market surveillance and correct use and training for all of this equipment, especially pulse oximeters. We always need to remember that they need to be adaptable, affordable, and the patient is always at the end of our activities, especially in COVID patients. So thank you very much.
Thank you very much, Adriana. The WHO resources are so informative and valuable at this difficult time. Wanted to make a statement regarding if you have any questions, please post those to the Q&A down at the bottom of your Zoom rather than in the chat. Now I'm pleased to introduce Dr. Pauline Bangudi from Rwanda, who will do the next presentation.
Thanks very much for this invitation. I'm very honored to be part of this Saving Life team. So my presentation will be about COVID, about pulse oximeter, its role in COVID patient. I'm trying to share my slide. And can you all see my slide?
Yes.
Is it visible?
Yes.
So, okay. Talking about pulse oximeter for COVID patients, I start by a clinical case where it's a 35 years old female which is brought at accident and emergency department in coma with a 1 week history of cough, fever, and shortness of breath. So her father reveals 2 weeks ago, she traveled back from China. So those are the typical case, including the case definition of COVID, when you see shortness of breath, cough, fever, and a history of travel abroad, not only abroad, but in a country where we know there was evidence of the spread of the disease. So after investigation, examined and investigation, it is revealed that the patient has multiple organ failure. So suppose that the patient on the bed, being rolled for prone position, already intubated in ICU. So here we will talk about pulse oximeter. PO stands for pulse oximeter for triage and screening. Pulse oximeter for critically ill patient in hospital or in ICU, and the uses and the limitation. The last one will be just short because there is someone who will go deeply into that. So I wanted to bring back this slide coming from Professor Donner from last presentation of last Tuesday, where he was talking to us about hypoxia and all the complication of hypoxia. When someone is having signs of hypoxia and we don't fix the signs of hypoxia and he keep having that hypoxia, he will develop a lot of complications, starting by interstitial lung injury, self-induced lung injury, and parenchymal lung injury. All those will be developing as we are leaving that patient under hypoxia. So by the time he reaches the hospital, he's in coma, like the lady, it's already late. She's in multiple organ failure. So she's a patient to intubate and to be in ICU. This next slide is showing us a pulse oximeter. And the article, which was published, Effect of Routine Emergency Department Triage Pulse Oximeter Screening on Medical Management, that article shows that with that history, traveling abroad, and 1 week history of cough, fever, and shortness of breath, this patient was a case definition. And we could detect hypoxia with a pulse oximeter. Either she went to see a family doctor or in the clinic or at home. If she could have a pulse oximeter at home and put on her finger, and she could detect hypoxia and start as early as she could treating it with oxygen or attend an hospital before even entering ICU. So this is showing the benefits of a pulse oximeter in an early state of the disease, when you're having shortness of breath, fever, and a cough. Something is happening in the lungs. There is oxygen is not diffusing properly from the lungs into the vessels, into the blood to be detected. So if you have a pulse oximeter, it can help detecting how much oxygen do you have in your cells, you have in your finger, to know if it is enough for your metabolism. As you are delaying, there is anaerobic reactions starting in your body and some vasoconstriction as a result of compensation, which will end up putting you into multiple organ failure. And so when you reach the hospital, it is too late. So first of all, we can see that in triage and screening, pulse oximeter is needed. Maybe at home or at emergency or in all the houses where we have those patients or elderly patients, we can have pulse oximeter. So we screen regularly people who are coughing if they have hypoxia. The next slide is showing the use of hypoxia and the benefit of it in an actual ICU, being for COVID or not COVID. So we know many patients have shown and is presented with ARDS, acute respiratory ARDS, acute respiratory distress syndrome, where they will present with hypoxia. So there is a quick test to diagnose acute respiratory distress syndrome, which is called the Kigali modification, which in the past, as you can see this slide, people with the Berlin criteria, people used to wait until you have a partial pressure of oxygen to find the oxygenation ratio. You need to be on mechanical ventilation with a PEEP, and then you have to use CT scan and X-ray. So this is a typical patient in high developed country. In many low-income countries, those patients, we don't have a blood gas machine to get the PaO2. Very few will be on vent, and CT scan doesn't exist, or it will be late by the time you reach there. So this Kigali modification score help patients even at emergency where you don't have a blood gas machine, you can have the pulse oximeter. So by the pulse oximeter, how you are saturating, comparing to your FiO2, which depends on the mask. If you see, we have normal mask, we have non-rebreathing mask. Those one, you can know which FiO2, inspired fraction of oxygen you are giving to your patient by detecting which mask are using. So with having which mask your patient is needed to saturate either 97 or what, can give you an image of the oxygenation ratio. You don't need a PEEP. So it means even without PEEP, even before intubation, you can detect an RDS patient. And other modification are, you can use just a quick ultrasound. And we know ultrasound is becoming really common in many hospitals before. So you can, with those elements, you can diagnose as early as you can many patients with RDS and know when to transfer them to a high developed hospital, or if you can keep them in these hospitals. So this is an ongoing tool. Many people are trying to check if it is valid, but it has been validated. So it's being used in many countries to validate. So SpO2 is at the middle, on the center, and it helped a lot to tackle all the RDS at the beginning. So the uses and the limitation of pulse oximeter, that one will be discussed on by another colleague, the next speaker. So you see that the common area where a pulse oximeter is used, mostly it is detecting the cardiopulmonary reserve of oxygen. The good thing is not only the saturation, but also the heart rates. And if you know the variation of the heart rate from the bradycardia to the tachycardia, you can really interpret. Your patient can have 100 saturation, but with tachycardia. Means something is going on. Maybe it's pain, maybe it's another cause, maybe hypoxia, which is being compensated. So this will be a call sign. Also, if you are very well trained to detect this curve, to know how to read the curve, you can learn a lot from this curve. That's why we advocate for all pulse oximeters are useful, are good, but the pulse oximeter with more advanced with curve will help you knowing the notch and read some other data, which in other situation will need advanced monitor. So pulse oximeter can give you a lot of data. But there is some limitation where you may have bad reading because of not zeroing your SpO2, or because you are not well perfused, you are being vasoconstricted, or with the nail for the women when they put on the nail some colors, it can be difficult to read. Also, some other like methemoglobin or monoxide of carbon. So there is some limitation which you need to fix before knowing if your pulse oximeter is working or not. So in summary, we know that the pulse oximeter is part of the standard monitor for safety, and it has revolutionized really medicine, especially perioperative medicine and critical care. We now need to put emphasis on pulse oximeter as a triage and screening tool, and it can help us detecting the sickest, the very sick and the mild sick patients at emergency and know how to direct them. And also we need to learn how to troubleshoot so we can get a good use of the pulse oximeter. Thanks very much.
Thank you very much, Dr. Bagbuti. Our next speakers will be Sharifu Rajabu and Ali from Tanzania, and they will be talking about the clinical engineering side of pulse oximetry. Looking for an informative presentation. Thank you.
Okay, thank you. It is my pleasure to have this opportunity to share what I have in the fight of this disease, COVID-19 disease. Can you go to the next slide? So, as Adriana said, the pulse oximeter, it ranges on different aspects. We have the fingertip pulse oximeter, we have the portable one, and also we have the tabletop pulse oximeter. All of this, they do differ in its accuracy, and we have to find where can they be used, and how do we know which one is so accurate compared to the other one. So when we come to this fingertip pulse oximeter, most of them, they tend to be not accurate, especially if you are trying to measure those values of oxygen saturation that in a hypoxic level. So always its accuracy tends to decrease as you go to hypoxic value. You may find that if you're using a tabletop pulse oximeter, the saturation of the patient is reading about 60%. And when you do trying to measure using the pulse oximeter, that is a fingertip, it is reading almost about 80%. So due to this, it may result into wrong diagnostic procedure, which may result into also a wrong therapeutic procedure. So how do we know all of this? And where those pulse oximeter are going to be used? Although even though the fingertip pulse oximeter, they are inaccurate on the hypoxic level of oxygen saturation, it doesn't mean we have to discard them, especially on this period where we are in shortage of medical equipment. So what I suggested that those fingertip pulse oximeter should be used by those patients who are in mild condition, or also for pre-screening to determine which patient should require to take a COVID-19 test. So it can be used for threshold detection. So the symptom of headache, increase of temperature is a result that the lung is getting some infection. But the pulse oximeter will give much earlier detection. This patient is undergoing some kind of respiratory problem. So if its oxygen saturation starts to drop, we may just consider this patient should undergo a COVID-19 testing. So those fingertip pulse oximeter can be used either for monitoring those patients that have supposed to take self-isolation at home, or those that are in ward that they don't need critical care attention. But for those patients that in ICU, we are supposed to use those tabletop pulse oximeter. They can give a good trend of oxygen saturation, and they are accurate at both levels of oxygen. So even the patient have lower oxygen, it will also tell us the true oxygen saturation of the patient. And if also it is going a recovery process, it will indicate the indication that is the actual oxygen concentration of the patient. Can you go to the next slide? So here I just try to speak about the specification of pulse oximeter and its calibration. For the specification of pulse oximeter, they are usually specified by the manufacturer, where we can find the accuracy of the pulse oximeter and also its repeatability. For the case of calibration, the pulse oximeter, always clinical engineer and biomedical technician have to look about this calibration of the pulse oximeter. But most of them, they once calibrated and they calibrated by the manufacturer. The most principle that is used by the pulse oximeter to take its measurement, they do consider the ratio of oxygenated hemoglobin and deoxygenated hemoglobin. So due to that factor, almost the error that may be to aging of the pulse oximeter will be cancelled. So if the pulse oximeter is not accurate, or it is deviating so much from the true value, always it means it's the error that may be miscalibrated during the manufacturing process. Although even this pulse oximeter that are cheaper, known as fingertip pulse oximeter, they are already cleared by the FDA, because they most of time they do calibrate the pulse oximeter using this pulse oximeter simulator or vital sign simulator on the normal level of oxygen saturation, maybe starting from 90% to 99%. So it is difficult to understand this pulse oximeter. They are not accurate at the oxygen level below 80 or 80% up to 60, which they tend to produce the results that are not accurate. Can you go to the next slide? So here's what I was saying. We have diagnostic with as monitoring, where are the application of specification and diagnostic. So those pulse oximeters that are not accurate, saying that those the fingertip pulse oximeter, they tend to be inaccurate on the lower range of hypoxia level. They should be used by those patients that are self-isolated, that don't need a critical care condition. But what we need to think about also, this pulse oximeter, although they are calibrated by the manufacturer, they need to be verified to see if they're still working within the required conditions, so that we can determine which one is accurate and which one is not accurate. How do we know that? So we have to use those vital sign simulator. So even those vital sign simulator, we need to understand how they operate. For example, on my side, I was using a BC biomedical finger sim simulator. They do have a fingertip similar to a finger of a human being, but inside they are filled with a certain fluid. So that same fluid, they are designed to mimic a certain oxygen saturation, but they have been calibrated at a certain temperature. So you might find that during its fabrication, it was calibrated at the environmental temperature of about 22 degrees of Celsius. So when you are using a pulse oximeter, you have to consider that also, because even on the its specification sheet, they do provide you with a graph that indicates the variation of temperature, how the temperature increase with the increase also in oxygen saturation. So on my side, the ambient temperature is about 28. So I just inserted the fingertip that read 92%, but you might find that the pulse oximeter, it is reading 95 or below, even 880. So with that condition, you might end up saying that, oh, this pulse oximeter is not accurate and it is not working. It was supposed to be,
Phil,
it is
you
not
need
supposed
to
to be used.
finish up in the next 30 seconds. Thank you.
Yeah, okay. It's not supposed to be used. So, but if you consider the chart of the temperature and the oxygen saturation, you will find that how you can correlate the variation of temperature with the oxygen saturation. Can you go to the next slide? So these are the limitation of the pulse oximeter. So you have to understand the error that can result due to pulse oximeter. And most of them, for example, this one, the problem number which is no signal or SPO2 of zero, it means that maybe the SPO2 is not plugged to its unit, or even the probe is not properly placed to the patient. So most of this, they are error that relate to the user, and the most common error on medical equipment that we have to check of them. We just try to analyze much of the error that can happen. And I think you might find on the other side that explain them that may result the pulse oximeter to produce wrong results. So that is what I have for today. Thank you.
Thank you. And Ali, you can pick up on the next slide. Thank you. Next slide.
Hello. Okay, thank you so much. The demand for technical personnel to maintain hospital biomedical equipment is very high. With rapid increases of different types of human diseases, such as COVID-19, cause electrical and biomedical engineering response to several government initiatives to improve and modernize health service for the country. As you can see, so far we have 18 students graduated this year, 2020. We have over 150 ordinary diploma ordinary diploma technicians since 2014, and we have 240 current enrolled in medical diploma and bachelor degree program. We have different students have to visit different hospitals through industrial practical training. We have calibration equipment, as you can see. We have lab training devices, example of 12 lead ECG, vital sign, defibrillators, ultrasound, and so forth. We have we have attended a summer training, which is organized by Duke. We have also exchanged program with the Clemson University, Cornell University, based in USA. We have 2 master's degree faculty who have attended in China, the same as we have 2 faculty who have attended the PhD program in Cornell University. Thank you so much.
Thank you very much, Ali. And Sharifo, thank you very much for that presentation. Very informative for our audience, especially being in the clinical engineering trenches here, working against COVID-19. So it's very important now. We're going to be going into the session on questions and answers. So we have a number of questions that have popped into the Q&A, which is where the questions should go. We're going to they basically go into some different categories, calibration, other devices that may either offer a better source of respiratory monitoring, devices that may replace the particular characteristics of the pulse oximetry. So let's go to the first question that had come in regarding recommended pulse oximetry verification guidelines protocols. What is required in terms of calibration? What are alternative calibration methodologies? So I pose this question to any of our panelists.
Toby, restate the question one more time.
Yes, the question is regarding requirements for calibration of pulse oximetry equipment. What is required? What is available? What are alternative methodologies for calibrating pulse oximeters or understanding that they are working properly and accurate?
I can field that question. Currently, Fluke and BC Biomedical are among manufacturers that make pulse oximeter simulators. These are like artificial fingers. I think Sharifu mentioned that. At Arusha Technical College, we have the finger sim. I think what he was trying to mention on that regard is the finger sim maybe in some ways has some deficiencies relative to the Fluke in that it can be temperature sensitive in trying to create this simulated finger. However, that is the best tool that we have right now for field calibration of pulse oximeters. Generally, you would want to check that they are accurate to within the manufacturer's specifications, which are typically 2%. You'd want to check, for instance, at, I believe their finger sim modules are at 97%, 90%, and 80%. Whereas most important, of course, is the hypoxic levels, and that tends to be where they are least accurate.
And let me also point out that when we managed a fleet of tens of thousands of pulse oximeters used in hospitals and nursing homes throughout the US, those simulators were not available, and the ones that were unaffordable. We had 150 field service engineers and technicians, and it simply wasn't possible. So we used a very rudimentary method, which was to put it on your own finger. If you're healthy and the reading is approximately 99, 100%, that's at least an indication that the device is reading something useful. If you put it on 2 or 3 people who are healthy and you get the same results, that is another suggestion that doesn't tell you anything about the 80% patient. And while I'm mentioning the 80% patient, I'll take the opportunity to point out that the literature does have some articles that suggest that persons with dark skin pigmentation can cause errors, significant errors at the 80% level by reading false high, excessively high readings. And that's an area that perhaps is understudied, but it is something to be considered as we work with patients in many countries that have a darker skin pigmentation, because that could be an erroneous reading that leads to either a bad diagnosis or incorrect screening decision.
Another important question has come in from Bill Gentles. I believe that this could best be addressed by perhaps Adriana, related to the finger probe used for screening. If the pulse ox is used for screening, what is the next steps to clean that probe, decontaminate it? Is there disposable finger coverings that might be available? Or I know that there are publications that address this issue.
Bill and the rest, yes, actually the book does talk about the different uses, the decontamination, even the maintenance issues for all of them, for the fingerprint, for the handheld, and for the tabletop. So we just put them as guidance so that the users can read them, but eventually, of course, there are specific procedures that one wants to expand on them. But the basic cleaning and maintenance procedures and even the check are in the book. Just to give the answer quickly, no? But yeah, thank you.
Thank you, Adriana. Also, we have a number of questions that are related to interference, limitations of pulse oximetry, sunlight, movement, various interfering sources, carbon monoxide poisoning. Also, the WHO has excellent resources related to this. There are tutorials on pulse oximetry. I don't know, Adriana, if you want to expand on that, or others.
Sorry. Yes, Toby, we have a, I cannot, well, I can put the websites on the chat as I've done for the first questions that we got, where people can find more information about the use of the pulse oximeter, but actually much more has to be done, much more has to be published, and much more has to be available for all kinds and all settings. So now maybe with the use of the pulse oximeter widely for COVID and others, it would be much more available information for the use of COVID, specifically for health centers or in rural areas or in places with warm weather, high humidity, and then the roughness of the use of the pulse oximeters, depending if it is a finger tip or tabletop. There have been some studies of taking the pulse oximeters into health centers and special low resource areas. And the idea was how can we ensure that they are available in all these settings? There was initially, and this is, I'll find the source for that, and then maybe I can send it to Tom to distribute. But there was even a paper because the idea was to encourage that in every health center, as they have a blood pressure measurement and so that they should also have a pulse oximeter. But then it was seen that it was not used. So what was the problem? The problem was that the healthcare worker didn't know how it could serve their diagnostics. The problem was that it was not available, or it was not working, or he or she didn't know how to use it or how the best use of it. So I think there should be much more training on the possibilities of having the pulse oximeter as a first diagnostics. And the moment you do your blood pressure measurement and take your scope, use your pulse oximeter. If that were done at the very beginning, many childhood pneumonias and other things will be detected immediately in the healthcare centers before even the person, and then can triage and send the person to the patient, to the hospital or whatever other reference. No? So there is a push for that. Now we're using COVID as a way to push availability of oxygen, but also a way to push availability of pulse oximeter. So that's something that we have to promote widely in all kinds of centers, even for non-technical, doctors or nurses, but even healthcare workers can use a pulse oximeter wisely if teach so. Thank you.
Thank you, Adriana. As you say, the pulse oximeter is essential for diagnostic monitoring in any patient that gets oxygen. There had been some questions regarding standards and regulations, and I think it would be appropriate. We have two panelists that have put together some material on this, Yadin David and Elliot Sloan, regarding particularly regulations in the US. So I'm going to turn this over to Yadin first.
Thank you, Toby. Sharifo made a great presentation of the role of clinical engineer in the assurance of the performance of pulse oximeter. I have an old pulse oximeter here. Here is the instrument, and this is the finger pulse. And it's so simple. You push a button and you get the reading. There is an error because I didn't put the pulse sensor on my finger. You can see the light shining. And if I put it on my finger, they're going to be starting a pulse reading and on the instrument, and I'm getting pulse oximetry reading. It's so small, it's so easy to carry, it's so easy to give to somebody, but yet there are some special needed, as you can see here. There are some special needed measurements and guidance to understand what does it mean when you get a product like that. And one of them is the understanding of regulation. The two major body of regulatory agency in the world right now are the CE mark in Europe and the Food and Drug Administration, FDA, in the US. The pulse oximeter has been invented by a Japanese engineer almost 45 years ago, Takao Ayowagi, I believe, if I'm pronouncing his name right. And he just passed away, unfortunately, early this month. But it became to be known as the 5th vital sign monitor. It's so, as I said, so easy to apply. So where are we going with this regulation question? The FDA does not, as Sharifo said, check the accuracy of the devices, does not test devices, period. Also, not testing pulse oximetry. What the FDA does is classifying the risk of the device to patients and users. And all the oximeters, regardless how they're using, if they're used in sports, in aviation, in nursing home, in homes, or in the hospital, are classified as a class 2 device, saying that they must be manufactured in certain quality processes, that they must have appropriate documentation, and that they are not hurting patients. There's nothing about accuracy. There's nothing about calibration. So therefore, what I would like to emphasize is that any vendor that claim that they are FDA approved are stating something that is impossible. The FDA does not approve. The FDA clear device to market, meaning allows you to sell it. It does not say it is safe. It does not say it's accurate. You have to read the instructions for use to really see what is the accuracy, and you have to test it to really verify that. As I said, they are small, easy to send, easy to deliver, easy to apply, but at the same time, they have variety of algorithm and detection and light emitting diodes that need to be maintained, clean, and calibrated. So my comment to the audience today is that you must check the pulse oximeter to validate its accuracy. When you receive it, you must maintain and service it, and you must clean it. Unfortunately, most of the pulse oximeters are tied to the patient. So if we're talking about COVID patient, that means it's in the environment that need to be cleaned afterwards between patient, and that healthcare provider need to be careful when they're handling those devices between patients. Thank you.
So let me jump in. Thank you, Yadin, and offer some other thoughts. I mean, about 2 months ago, I purchased some of these low-cost devices, and I carefully screened them on Amazon to be sure that they suggested or indicated that they were listed with the FDA and CE. One of the items that I got, there's no indication on the box or on the literature that I received that has anything related to CE or FDA. The contact one does have a CE mark on it, and I can find and I can trace CE, and at the time I could trace FDA indication at their website. Today, Contact has removed all of their FDA and CE notations from their website, and it's disappeared from all of the sales on Amazon, Alibaba, eBay, and any other sources. So, I have to assume that the volume production that they're going through, they've made a strategic or business decision or liability decision to discontinue those claims. The concept of claims and claims made is important to understand with the FDA as well. The FDA bases a lot of their decisions and interventions on claims made. And medical claims, if a manufacturer says that a product is for diagnostic or therapeutic uses, typically in a hospital, they will charge more, and they are in the highest level of stringent oversight by the FDA. The FDA has two other categories. One is aviation and sports, and a third category is just called wellness. And those presumably, the buyer beware, make some decisions about the approximate accuracy and utility for their own needs. The aviation, if one's trying to decide if one might be oxygen starved and make dangerous decisions flying a plane, that has a degree of risk that is different than wellness and fitness or exercise, which also has risk, but it's within the personal use. A lot of the current products that I find on Amazon and Alibaba and other vendors now have explicit statements, not a medical device. So I assume they are making, at least for the time being, a statement to bypass regulatory intervention. So it is a serious challenge right now. The market is depleted of products, and for most of the vendors I see on the market today, they are new vendors that have not been visible before, and they only have very few comments or feedbacks. So buyer beware. And in the chat box or the question and answer, I said that you probably have to test 100% of them coming in to make sure that whatever you receive, in fact, is functional.
I'd just like to add what Elliot said. Our anecdotal evidence from using pulse oximeters in teaching at Arusha Technical College. We have up to 30 pulse oximeters tested with our FingerSim device. And what we generally find is in the range above 90 degrees saturation, most of them are accurate. And also most of the papers we've read have reported the same studies, that if you're looking above 90%, you're generally within a few percent of accuracy. So if you set the threshold at 90%, as was mentioned, for hypoxia, silent hypoxia, you can probably get away with using most inexpensive devices.
Comment? Toby?
Yes, Adriana.
Can I comment quickly?
Yes. Sure.
I think, well, you're touching into some important points that we have it not only in pulse oximeter, but also in EKG and many other things. So we have devices, or even in masks, when we were talking about non-medical masks. So we have non-medical masks, we have non-medical pulse oximeters, we have non-medical EKGs when people are talking about measuring oxygen saturation or measuring your pulse or measuring EKG or protecting with the mask. So these are non-medical issues, non-medical articles, let's call it that way. And then there are the ones that are medical, that have been registered, that they do all the compliance, and they will have the FDA approval or the CE mark or the TGA or the Japanese authority, etc. And they went through that process. There are many others that do not go. So this is also an area of much interest of us as clinical engineers and also on regulators on saying which devices go the wellness path. And so because they said they're for wellness, they're not a medical device, they're for health, but they're the ones that are really used for diagnostic monitoring, etc. And they have stringent regulatory pathways, stringent compliance to standards, etc. So I think we really need to distinguish between those two products in many of the medical devices. And now many medical devices are becoming devices that are also sold by any others that are not really a medical device. So I think we have to make that difference and be sure to explain that to the users so that people might not be confused that they have a very good compliance with standards or compliance with testing or so, if they were not classified as such. So I just wanted to comment on that. Thank you.
And very briefly, before we conclude, I just want to point out the classic way of trying to make sure your devices are accurate is to maintain one device as your reference standard and compare other device performance against that one device. All other things being equal, if you can at least keep one device as your gold standard, it's easier to ensure the other products are working properly.
Thank you, Elliot. So we need to close up with the conclusions of the town hall now. We've covered a lot of subjects. We know about the resources and work of WHO on the clinical side, the clinical engineering side. We will be answering all of the questions that have been posted, and you'll receive the answers there. So I'm going to bring this over to Tom for final words.
Thank you, Toby. Great job. And we appreciate, I've seen what 20 in the Q&A section and then a good running stream in the chat section. Some complex topics. Not going to try to recap everything I've heard here today. I think one big issue we've heard over the 4 town halls so far, and we'll also emphasize it next Tuesday, is we need to fill out that inventory tool that Adriana's talked about. Before this is over, we'll put how to do that online again. As she said, she's got some data, but needs a lot more to really be able to distribute information, not only information, but equipment and accessories around the world through the process of how that's been working. Once again, of course, 5 webinars, including the ventilators through next Tuesday. You've seen schedules before that cause there to be perhaps more town halls after that. For now, there hasn't been volunteers coming forward, and those topics I think may be slightly of less interest to this body of people. And so we are suspending the town halls after next Tuesday. There's the possibility of one a week from today on Friday, the what's that, the 22nd, to answer a lot of these remaining questions that we've been gathering answers from the experts from all over. So in recap, there'll be the ventilators on Tuesday, the 19th, and perhaps a question and answer across all 5 topics on Friday, the 22nd. And we really appreciate a lot of attendance. We've averaged about 250 folks from registering for these from 60+ countries. Adriana, other comments from you in closing?
Just to thank you very much, everybody. Thank you for sending these seminars. And the idea is to collect all the input and then be able to share it with you on responses. But also we need to keep on working for COVID altogether. We would need to have some training material. We need to review standards. We need to validate products coming into the market. So we will be asking for help from all of you because we need to do this together. And thank you very much, and always thinking on the wellness of patients. Thank you all, and stay safe. Thank you.
Back to you, Toby, to close.
I'd like to thank Adriana, all the presenters, the panelists that have responded to questions, and all of you who attended the meeting today. So again, we'll be getting out the answers to the questions. I know some of them are in the chat, so we'll pull those out also and get those out to you through IFMBE-CED. Thank you, everyone.
And as always, this recording will probably be out by tomorrow. Appreciate it, and bye.